I'm going to talk to you about how our everyday purchases affect our health. And for the remainder of this talk, I'll call it consumer purchase data. I'll start with a brief introduction and background, move through a cosmetic ingredient footprint, then I'll talk a bit about diet and consumer data and wrap up. So before we start, I would like you all to raise your hand if you're a member of a loyalty program, receives digital receipts or personalized offers. Increasingly becoming available through loyalty programs and digital receipts. And every time you walk into an average supermarket, you have all the items on the shelf to choose from. And actually that means that every time you receive the digital receipts, you will answer a 20,000 item yes/no questionnaire. It also means that we have continuous data collection over the year, with each household generating hundreds of receipts each year. In addition to that, your choices are already influenced by the loyalty programs that you are members of. And that means that this is actually a target of prevention. And as such, I think that the consumer purchase data emerges as a possible solution to assess and communicate the health effects of consumer products. I promised you a cosmetic ingredient footprint. I don't know if we can get that, but we can get close. There's been increasing focus on potential harmful effects of consumer products and consumer chemistry. In the EU, we have the REACH database, which is a comprehensive mapping of chemicals used in the EU, but less is known about individual exposure profiles, as they are typically very hard to obtain. So the aim of this part of the presentation is to obtain a cosmetic exposure profile through enrichment of consumer data, providing us with an individual cosmetic ingredient footprint. So in Denmark, we have this GDPR compliant, secure, encrypted web application that collects digital receipts from 3 of the 5 largest retailers in Denmark. We have, in addition to that, personal identification numbers on all the subjects that allows us to link to registry data and that have generated 78,000 receipts since 2014. And that resulted in 96,411 unique products. We merged that data with data from the Danish Consumer Council Kemilupen app, that is an database that has 22,600 cosmetic products that are all classified according to suspicion of being harmful or being hormone disturbing. And that resulted in a total of 2,118 cosmetic products. And our participants purchased from 1 to 615 unique products with a mean of 58 in the period. All these roughly 2,000 products resulted in 1,948 cosmetic ingredients that were identified. That's what you can see in the word cloud on your right-hand side. I think maybe some of you will recognize some of the ingredients. That also resulted in that each participant purchased on average 167 different cosmetic ingredients in the time frame from 9 to 648. And there was at least, on average, 19 products with at least one problematic ingredient inside this. On average, 30% of all cosmetic purchases contained at least one problematic ingredient. So from this, we can see that it's possible to collect a cosmetic ingredient exposure profile on an individual level. We could also see that most participants were exposed to problematic chemistry, and there was a large variation in the number of chemicals and potentially harmful chemicals among the participants. Now I'm shifting the focus a little bit, focusing on diet. And our department at Statens Serum Institute, we do outbreak work. And on average, we have more than 100,000 people affected by foodborne outbreaks in the EU each year. Around 40 to 60% of those are solved. But could we use consumer purchase data to improve our success rate in solving these outbreaks? We tried to find out that using a large anonymized consumer data dataset together with our colleagues from Folkehelseinstituttet in Norway. And we simulated multiple outbreaks from many different product sources. And we found that we only needed 5 cases on average to solve the outbreak using logistic regression. So our assumption was, of course, that the outbreak was originating from consumer data. We also found that looking at analysis of individual products rather than product groups were a lot more efficient in solving the outbreaks. Other people have looked at consumer data, and I was lucky to be part of this paper. In this paper, we looked at purchase patterns in households with and without diabetes, and we found that the largest monetary percentage on all households, whether they were diabetic or not, were used on sweets. And we could also see that households with diabetes tended to have a higher monetary percentage used on unhealthy foods than households without diabetes. So from this we can say that analysis of consumer data on product or product ingredient level can improve or supplement our ability to detect rare diseases or solve outbreaks. And we can also see that we have the potential to detect associations to chronic diseases such as diabetes. You might start thinking about what about all the limitations, and luckily we have the Finnish low card study. That's the large loyalty card study from Finland. And what they found is that participants in these kind of loyalty programs, or at least the Finnish one, did diverge from the general Finnish adult population. But they also found that it seems quite capable of describing food consumption when comparing to food frequency questionnaires. There were some discrepancies which are perhaps not surprising for fresh and cooked vegetables, berries and vegetable oils. But they also found that the higher the loyalty score, i.e. the more you purchased within this loyalty program, and for single households, they found a much higher correlation to the food frequency questionnaire results. In addition, they did a very interesting study on looking at motifs for choosing various food products, and found that low-income groups are very price-sensitive. That means that discounts targeted at these groups matter and are a potential target of prevention. So just to wrap up this discussion with some limitations and strengths. Right now we have a limitation in sample size. We hope to make that better in the coming years. We also have some selection, and we have some challenges regarding product coverage and being able to enrich these products, at least all of the products. We do not have consumer data from all retailers, nor do we have it from restaurants, but we're also working on that. And we have to take a lot of care about one-person households or two-person households or multiple households, as this affects the accuracy of the data we collect. We do also, however, have some quite important strengths. We can assess these data over prolonged time frames with broad assessments of multiple hard-to-access exposures. And when we do this with a very low time consumption from our participants, it means this is scalable and can be used. There's also not the problem of social desirability bias, which is also often a plague in many questionnaire studies. And potentially we have a very fast translation of our results if we can manage to make the right partnerships. So my take-home messages today is that large consumer data cohorts and product data could allow for epidemiological risk assessments of ingredients used in consumer products, and we can also generate consumer advice on how to avoid harmful products and product ingredients. Taking an example of an allergic person, you could provide some direct advice as to what kind of chemical ingredients you would like to avoid. So I think more research is needed, but I think in a few years we will probably know how our everyday purchases affect our health. Thank you very much for your attention.